Good afternoon, everybody. Hello. I'm very happy and grateful for the invitation of Professor Ximenez. And it's my great pleasure to demonstrate our experience in the anomalies of great vessels. Together with the Krakow team, we will take care of you of about 1 hour, 2 hours, or even more, depending on your activity, your interest. Our plan for today is to give you several issues. First, the lecture, together with the demonstration based on virtual reality. And next, we will finish our meeting today with the quiz. We are based in two sides of Poland. Together with the Krakow team, I'm here with Agnieszka and Adrian. Can you come to me, please? This is Agnieszka and Adrian.
Hello, Agnieszka is me.
we are based here in Krakow, and our colleague Peter is based in Warsaw, and we will be taking care of you during this meeting. Krakow is a wonderful place, and I hope you will be able to visit us on one of the following courses after the COVID story will end. So what will be presented today? I will give you a little bit of introduction on great vessel anomalies. Next, I will talk about the transposition of great arteries and quite similar from geometric point of view anomaly, which is double outlet right ventricle with subpulmonary VSD. Next, I will move to aortic dextroposition anomalies, which is mainly represented by tetralogy of Fallot. Next, I will talk a little bit on the common arterial trunk, and I will finish with L transposition of great arteries. So this is the theoretical plan. But in Krakow, we developed one thing, that one-man show doesn't work. And looking at my face, you may expect that there will be one-man show, but it's not like this. We will illustrate all these parts with virtual reality demonstrations. And Peter will help us, and he will stream from Warsaw all these virtual reality parts. So let's talk about introduction on great anomalies, great vessel anomalies. First, we need to know how frequent, how prevalent they are. And if you take bets when suspecting a great vessel anomaly on your prenatal scan, it's better to take your bets on tetralogy of Fallot and detransposition of great arteries, because these are the commonest in this group. The less common are double outlet right ventricle, common arterial trunk, and the level transposition of great arteries. And how it comes to the detection rates. If you look at detection rates, it's a different story. Tetralogy of Fallot and detransposition, which are extremely important from the point of view of ductal dependent lesions, because detransposition is always a ductal dependent lesion. However, some cases, many cases of the tetralogy of Fallot are also ductal dependent. Their detection rates are quite low. In Krakow, we have learned that from detection rate tables, we can enhance our focus on teaching in prenatal ultrasound. We can focus on the anomalies which are not as good detected as we expect. And this is why we are meeting today to discuss the great vessel anomalies. But it is promising that through recent years, thanks to the introduction of early anomaly scan and early fetal echocardiography, the detection rates are rising rapidly. Just have a look at the EuroCAD registry data for detransposition of great arteries. It was detected at the level of 35% between 2005 and 2008. But in the registry collected between 2009 and 2012, it doubled. So it means all the educational efforts, like those from your school of Professor Ximenez and the others around the globe, these causes that the transposition and also other great anomalies of great vessels are better detected, and detecting these anomalies saves lives, because many of these, as I mentioned before, are included in the ductal dependent group. So let me raise the question: why do we miss the detransposition of great arteries? If you ask pediatricians, if you ask neonatologists, they will tell you that detransposition is the least detected anomaly in prenatal life, because this is rewritten from one textbook to another. And let me explain from our point of view and from our experience of more than 10 years of teaching around Poland and also around other countries. First, I think we put too much attention on normal hearts. And just imagine you are a veterinary dog physician, and you have just cats as your patients. So when a different kind of patient is visiting you, like this one, or maybe this one, you are panicking. You don't know what to do because you are not prepared. Especially because these two species on the right side are less common in your practice. And this is why you need to be prepared for them, for their behavior, and for their clinical management. So the same as regarding great vessel anomaly. We are experts in normal heart. We know all about three vessel view, three vessel trachea view, and many other aspects. But we are not able, basing on that knowledge, we are not able to detect basic anomalies. If you look at experts when they are watching prenatal scans with cardiac anomalies, their introductory diagnosis is taken within minutes, within seconds, sometimes, depending on scanning positions. If the heart is available, they have the concept already. This is why is that? Because they understand the geometry, the individual geometry of each anomaly, and this leads them to the differential diagnosis and to the final diagnosis. This is why we would like to guide you today through the features of all individual anomalies, not basing on the normal heart, because normal heart is like a cat, and the other patients are less covered in many of the discussions. So there are plenty of combinations at the arterial segment of prenatal cardiac scan. However, it's too complicated to put it all together, and this is why we'll discuss them separately, one by one, and we will also illustrate this with virtual reality. That was the first reason. So I believe that we are not so focused on anomalies. We stick to normal. The second reason is this picture. We know this picture from all the textbooks. Believe me or not, but this picture is not so easy to visualize in detransposition during the fetal life. You have to rotate around the y-axis and also around the x-axis of your probe. This is why it's a beautiful picture for the textbook, but during your cardiac scan and the fetus, you rarely will encounter it. Of course, experts can do it easily, but to enhance detection rates, we have to focus on less experienced physicians who are dealing with prenatal ultrasound. The third reason in our understanding is the apical scan. and focusing too much on crossover of the great arteries. In Krakow, we decided to abandon talking about the crossover of the great arteries, because crossover means the level that the great vessels cross each other at the level of the valve. And when you are looking at this transposition from the apical position, you may have the impression that they cross. And please have a look at this picture. This will be in the faster clip, and afterwards I will give you the slower one. Here we have on the left side, the left ventricle, and the main pulmonary arises from the right, from the left ventricle. From the right ventricle, which is on the right side, the aorta arises and forms the arch. You can have the impression that the great vessels cross. However, this is a typical picture of detransposition of great arteries. So this is why we stopped teaching like this. And here you can experience the same clip in slow motion. I will use plenty of clips during my presentation in slow motions for better understanding of the prenatal pictures. I hope you can see it. So whenever you are scanning apically, you may have the risk of missing this crucial anomaly. Another reason I believe is the in-plane view of the interventricular septum. Sometimes we are catching this view randomly, and this view is only possible to be obtained in the prenatal ultrasound. When you're looking here, you may have the impression that both great vessels are parallel, and you may overestimate the picture and make a false positive diagnosis for detransposition. So when you rotate from an apical position, you may have the clear view of the interventricular septum, and then these two great vessels may look as they are parallel, but in fact they are not. Next reason is the poor understanding and maybe inappropriate naming of the upper mediastinum views. There are some views which are named similarly, however, they mean something different. We know that there is a three-vessel view and three-vessel and trachea view, and many authors, many teachers mistaken them. And we do it all the time. The difference is essential when you are talking about the great vessel anomalies. However, in the normal heart, there is not a big difference. Look at the normal heart. These are the inflows at the level of four-chamber view. This is the classical three-vessel view as it was described by you in 1997. When you move to the three-vessel and trachea view, you have the level when both arches are joining together at the level of the aortic isthmus. They, in the normal heart, they form the V sign. However, in the normal heart, there is not a big deal if you mistaken three-vessel view from the three-vessel and trachea view. But have a look at the conotruncal anomalies, so the anomalies of the great vessels. This is the normal heart in the upper left quadrant, the three-vessel view. If you look at the detransposition of great arteries, the signal from the aorta is pushed anterior and to the right from the main pulmonary artery. If you look at the tetralogy of Fallot, which is lower left, you have on the very narrow main pulmonary and the dilatation of the aortic signal. In common arterial trunk, you can see the big vessel that gives branches at this level. However, if you look at the three-vessel and trachea view, these three anomalies, they look very similar. Look, they form a singular arm of the V sign. I've taken these pictures from the same cases as shown in the previous slides. So if you are considering these two views carefully, as Tong Song has suggested in prenatal diagnosis in 2010, Then you can have and analyze properly the whole picture. What are the most common signs of great vascular anomalies? I would raise the first sign as I discussed in previous slide. So a singular arm of the V sign. The second sign I would highlight here when you have a disproportion between the main pulmonary and the aorta, especially when the main pulmonary is small, which may indicate the ductal dependent pulmonary circulation in the future. And the first critical view is when you see the overriding artery over the ventricular septal defect, because this vessel may be common arterial trunk, this vessel may be aorta in the tetralogy of Fallot, but it also may be the main pulmonary artery in the setting of double outlet right ventricle. So these signs are crucial. And let's talk now about the detransposition of the great arteries, the most important anomaly that has to be detected during the prenatal life. The prevalence of detransposition, generally speaking, is about 3 to 4% of congenital heart diseases. From geometric point of view, you must compare the normal picture, which is formed by two geometric determinants. The first determinant is the axis, the cardiac axis that is built from the ventricles, and the second geometric line is formed by the connection of the right outflow tract through the main pulmonary, the arterial duct, and the descending aorta. If you're looking at the observation from Professor Rudolph from State, he suggested that this straight line should be called as the pulmonary ductal trunk, because it's a straight vessel of the similar diameter as the aorta. At the level of the pre-vessel and trachea view, to this geometric line, the other line is connected, which is the transverse section through the aortic arch, and that is why they form the V sign. In detransposition, the first vessel that is seen is the vessel that arises from the left ventricle, and this vessel stays on the left side and bifurcates very early after arising from the ventricle. Almost at the same level, slightly anteriorly to the right from the pulmonary artery, you are able to visualize the aortic valve, and basing on the subaortic infundibulum, so the rim of the muscle that is located below the aortic valve, and the aortic valve itself, the ascending aorta and the aortic arch forms the right convexity sign that is clearly seen in detransposition of great arteries. So this relation is almost constant, but I would also mention about some exceptions that has to be discussed. So let's compare. We believe, together with Agnieszka and our other group members in Krakow, that learning based on comparison is the most effective. So let's try to understand these geometric features on the normal heart on the left, and let's compare it with detransposition on the right. Left ventricle, aorta, push to the right side. Right ventricle, main pulmonary, building this straight line. And slightly higher at the level of pre-vessel and trachea view, the aortic arm that builds the V sign. So this is the normal pattern. And now try to compare this picture with the transposition of great arteries. Left ventricle, main pulmonary, and the aorta, which is forming the sign. And this is constant. And every practitioner, in our opinion, who is dealing with prenatal ultrasound has to keep in mind this picture, because it is not like screening policy that we are just selecting patients who are needed to be sent to tertiary centers. It may be us who are meeting these patients with detransposition at the labor ward just during the pre-labor ultrasound. And this picture must be understood and remembered by all the people who are involved in prenatal sonography. Let's try to analyze some detransposition pictures. This is the apical position, left ventricle, the main pulmonary, and the right ventricle, the aorta. And keep in mind that this is a risky position because sometimes you may have the impression that they cross. This is why we stopped talking about the crossover of the great arteries. It's better to understand the sweep level by level, and then remember these critical views. Let's have a look at the detransposition from the subcostal view. This is the picture taken by Agnieszka. You can see here the bifurcation of the main pulmonary and the aorta finally building the singular arm of the V sign. Once again, bifurcation and the aortic arch as the only one vessel at the level of 3 vessel and trachea view. So I believe you are more experienced now. You're catching this geometry. So try to analyze this faster clip, because faster picture is what we have normally during our routine scans. Left ventricle, bifurcation of the main pulmonary, and the aorta. There is a VSD accompanying to this detransposition of great arteries, and what we teach here in Krakow is also one important thing. Try not to focus your attention on VSDs. The septal defect has to be analyzed at the end. According to sequential segmental approach, first we check the atria, the atrioventricular connections, next the ventricles and the ventricular arterial connections. Then we build the whole picture of the heart. Afterwards, we go into detail. I have to admit that before you look at the atria, you have to check the venous atrial connections first, because they will lead you to the characteristics of atrial morphology. Regarding the V sign, what is the V sign? Is the connection between the ductal arch and the aortic arch at the level of aortic isthmus. But you should remember that this connection is also present in the transposition of great arteries. It is present but rotated. I mentioned before that the aorta is positioned anteriorly and to the right. This causes that the main pulmonary is slightly lower, and this produces the lower position of the arterial duct. And here you can see that the V sign can be observed in the transposition of great arteries, but in sagittal view, in the simple detransposition of great arteries without accompanying anomaly. Now let's try to analyze some pictures mapped with color Doppler. Once again, normal morphology on your left and the transposition on your right. Left ventricle bifurcation and the right convexity sign of the ascending aorta and the aortic arch. The same picture is there from the beginning. So from the moment when the septation of the common trunk in early embryonic life was distorted. In 17-weeker, you can see the normal picture, and the features of detranspositions are seen the same as we were presenting before on the 20-week curve. Can you see it? I believe you can. Now, if you are talking about the early cardiac scan, and I think that the detection rates that were observed in EuroCat data are also influenced by better early cardiac scanning that is more common among the practitioners. We all remember that in the first trimester, two inflows and the V sign, these are crucial views, and in fact, color mapping is essential. It's even more important than the B mode signal, because sometimes B mode is difficult to read because of the lower resolution at these gestational ages. However, if you do the same way, scanning sweep, in detransposition log, you will see the signal from the main pulmonary and from the aorta. However, I would be very resistant to diagnose that we have the detransposition in this case at 12 weeks. I would be patient. I would rescan the patient in about 2-3 weeks time, because this can be a double output right ventricle with a pulmonary VSD, which has a very similar picture, and I will also demonstrate it later on. Exceptions are always there. They are in languages. They're also found in ultrasound. Look at this picture. Left ventricle, main pulmonary, and the aorta. And try to concentrate on the same case in color mode. What is different from the cases that we observed before? Here, there is an accompanying VSD, and probably related to this fact, the underdevelopment of the outlet portion of the right ventricle. This causes that prominent vessel, in this case, is the main pulmonary artery, and the aorta is smaller. This is why we are able to catch the aorta at the level of the V sign. This is why we are warning you against simplification. We know that some teachers are trying to make it as simple as possible, and there is a big risk, because if you understand this picture as 4-chamber view and the 3-vessel trachea view, 3-vessel view looks quite normal, and 4-chamber view looks also quite normal. However, in this case, we have the transposition of great arteries with VSD and the underdevelopment of the subaortic infundibulum. The VSD is not good from surgical point of view, but from the condition of the point of view of the neonate is good, because this is another point of blood mixing, and in detransposition, blood mixing is essential. This is why we are applying prostaglandins postnatally to maintain the blood mixing through the ductal arch. Otherwise, in detransposition of great arteries, we have two separate parallel circuits of circulation. One circuit is bringing blood from the lungs to the left atrium, next to the left ventricle, and from the left ventricle again to the lungs through the main pulmonary artery. This is one circuit. And the other circuit is bringing blood from the upper part of the body through superior caval vein, lower part of the body through the inferior caval vein, and coronary sinus from the heart to the right atrium, and from the right atrium, the deoxygenated blood is brought to the right ventricle and from right ventricle through the aorta to the body. So this causes the deoxygenated blood is brought to the tissues of the body, what causes severe symptoms. Whenever we are bringing the possibility of blood mixing, the symptoms are less severe. In this case, we have three potential mixing points. One at the level of the atria, through the foramen ovale. The second one through the arterial duct, if you apply prostaglandins, and the third one through the VSD. Whenever you have doubts, when you suspect a case as detransposition of great arteries, you can always go to the sagittal view. And sagittal view of the arterial duct, when you are guided by the line of the spine, will tell you that two great vessels are parallel. And independently, if you do it in the grayscale or in color mapping, the picture looks the same. From pulse wave Doppler, what can we expect from pulse wave Doppler? In the second trimester, it will just tell you that the stroke volume of the left ventricle, if you sample the main pulmonary, is effective. And also, if you sample from the aorta, you may say the same, but the spectra are similar. However, if you are closer to the third trimester, you can observe that the pulse wave Doppler signals are a little bit different. The signal from the main pulmonary artery is characteristic because of the fast time to peak velocity time. And this causes the very, very sharp rising of the maximum velocity. If you compare it with the aortic time to peak velocity, you will see that there is a slower peak, slower reaching of maximum velocity. So you can use this sign, but only in the third trimester, to differentiate from the which great vessel is which in cases of suboptimal scanning conditions. In detransposition, this is not only about detecting this anomaly. It is also about looking at the prognostic factors. The first prognostic factor is the interarterial communication. It's a very important part because whenever you have a restricted, meaning a very narrow communication between the atria, it may reduce the blood mixing, and also this related quite commonly with pulmonary hypertension. Second thing is that we are checking how much the foramen ovale flap is moving to the lateral side, the lateral wall of the left atrium. We should expect that at least 50% of the width of the left atrium is covered with the foramen ovale flap movement at the maximum point. However, if you look at this foramen ovale flap, please appreciate that it moves from the left to the right. Normally, it stays on the left side, and this is quite characteristic among the conotruncal anomalies, so the anomalies of the great vessels. It was highlighted years ago by Professor Lindsay Allen, who suggested that this is one of the first signs at the level of four-chamber view that should catch your eye before you start searching for the transposition of great arteries. And when you do the growth scan in these patients, you have to focus. In this case, we have a very wide interarterial communication, which is a good point for mixing of blood. And also the time of growth scan, when you rescan patients with detransposition, you have to concentrate on the size of the arterial duct. In this case, The duct is quite wide. This is why we have a potential, another potential site of blood mixing. And in Krakow, we have a very strong pediatric cardiology and cardiothoracic surgery center. They do plenty of surgeries. For example, for hypoplastic left heart syndrome, they do around 30 procedures, Norwood procedures a year. And they always taught us and recommended that when the pre-delivery scan is done for the growth, for the position of the baby, when the patient is admitted to the labor ward, you should look at the interarterial communication in cases of detransposition. And this is the pre-delivery scan. You can see the aorta. And this is the main pulmonary. You can see the typical features of the left ventricle. Very, very fine trabeculations are observed here. On contrary to the right ventricular coarse trabeculations that are found here on the anterior ventricle from this scanning point. And this pre-delivery scan showed very wide communication, and this message should be transferred to the neonatology team that it is a good prognostic factor. Also, we have to do it the same in color mapping. You can see the very strong signal of blood across the foramen valley. However, sometimes we can encounter severe cases, and this kid unfortunately died. And one of the reasons was the restricted communication between the atria. You can see very tiny communication, and also if you look at the foramen valley flap, its movement is tiny. The narrowing is clearly seen. This kid developed very early pulmonary hypertension and was and unfortunately died. Very similar from the geometric point of view to this anomaly, which was described, is the double outlet right ventricle with subpulmonary VSD. This anomaly is called by many authors Tausig-Bing anomaly. Here we have the structure of the heart, which is based on usual atrial arrangement, concordant atrioventricular connections, and the ventricular atrial connections, the ventricular arterial connections in the setting of double outlet. The double outlet is always connected with ventricular septal defect. The blood goes out from the left ventricle through the VSD to the main pulmonary artery, and from the same right ventricle is pushed to the aorta. This causes the similar physiology as in the transposition, because look, from the left ventricle, the blood goes to the lungs and returns from the lungs through the left atrium next to the left ventricle. Regarding the right atrium and right ventricle, the blood is pushed to the body. So it looks the same in the same physics from physiological point of view and also from geometric point of view. Here you have an example: left ventricle, left atrium, right atrium. There is a VSD, and very often these cases demonstrate the dominance of the right ventricle, which is together with VSD, which are the first two leading points that bring us to the careful evaluation of the great vessels. If you look at the same case, with the focus on great vessels, you see the VSD, main pulmonary artery, and the aorta. It's very clear, and Tausig-Bing anomaly is based on two infundibula and side-by-side position of the great artery. This is another example. left ventricle, right ventricle, main pulmonary, and the aorta. If the great vessels are of comparable size, then you will see the same picture in the first trimester as in the transposition of great arteries. This is why it's better to be careful and not to diagnose the detransposition too early. Detransposition may be found also in complex anomalies, and this is the tricuspid atresia. You can see the hypoplastic right ventricle, and here the detransposition was also observed. Now, I would like to ask Peter to present features of the normal heart on the virtual reality system. And then we will try to demonstrate the features of detransposition and double outlet right ventricle with subpulmonary VSD, also using the same system. Peter, can you hear us?
Yes, I can hear you. I hope you can hear me also well. What I will do now, I will use our setup. So I'll use goggles, the VR goggles that I will wear, and the controller that will act as a simulated ultrasound probe. And I will share my image, so what I see in the goggles, with you on the screen. So I'll start the presentation.
Should I use Safari to watch you?
Yes.
All right, I'm there. Peter, do the audience hear me also?
Yes.
Oh, thank you. We can see that you are there in the virtual reality system already.
Yes, I'm starting to work, and I'll start to share the screen with you in a moment.
All right. Excellent. Peter, can you start with showing us the normal heart?
Yes.
Okay, with the focus on the great vessels. I hope the audience can see clearly the descriptions of the anatomy, which are shown at the top. Peter, can you move this system? Oh yeah, that labels can be seen.
I'll try to move my head very slowly, for everyone will be able to follow. All
right. So this system we developed for our preparation for anomalies, because by using that you can learn in a quiet environment at your home the features of typical anomalies, and you can learn and check from various angles the typical form. Peter, okay, what can we see here? We have left atrium, right atrium. Okay. Can you show us from the beginning? So please move to the IVC first. Yes, IVC is entering. This is the constant feature. It's entering the right atrium. So we can see that the right-sided atrium is the right atrium. Now move to the left atrium. Yes, and let's try to visualize the pulmonary veins. Oh, yeah, they are coming. So it means that the veno-arterial connections look normal. We don't know yet about the SVC, but this is in constant and we can wait. So let's have a look at the ventricles. Just by looking at the shape of the left ventricle, We can see it's a bullet shape. The trabeculations are very fine. There is no moderator band. The trabeculations in the right ventricle. Peter, can you show us the moderator band?
Yes, I'll.
Yeah, please do. Oh yeah, it's there. You can see it. That's perfect. So there is a band of muscle that arises from the interventricular septum and is attached is attaching towards the free wall of the right ventricle. Now, if we move to the great vessels, I can see that you are starting showing the aortic root, not the aortic root, because we are not sure that this is the aorta. This is the vessel that arises from the left ventricle. Yes, can you show us if this vessel is not bifurcating? No, it's not bifurcating. Great. And now you reach the level of the right ventricle, and I can see that there is a left pulmonary artery, and I can see the duct. So the branches were there, and now we can see the straight geometric line connecting the right ventricle, the main pulmonary, the duct, and the descending aorta. And we can see the free vessel and trachea view because this line is joined with the aortic arch. So this is the geometry of the normal heart. Perfect. Peter, you do it interactively, so you are just sweeping through the heart.
Yes.
Can you try to demonstrate the same on the detransposition of great arches model?
Yes, I'll just put the image to the whole of the screen. I don't think I'm just wearing goggles here, so it will be better that everyone will see the full image.
Excellent.
Okay, and we need the detransposition.
Yes.
Perfect. I'm there.
Excellent. And let's try from the beginning as the segmental sequential approach is recommended. So IVC as should lead us to the right atrium. Yes, let's go further. We have the right atrium finally. Yes. Now let's move towards the left atrium. Okay, good. We are waiting for the pulmonary veins. One of them is seen. This is the artery. So I can see one of the veins. Oh yeah, now some veins are seen. So it means that at least two pulmonary veins are draining to the left atrium. Now looking at the morphology of the ventricles, and we can see that the left ventricle is connected to the left atrium and the right atrium is connected with the right ventricle. Both AV valves are patent, the cracks of the heart is normal. So let's try to analyze the great vessel. Let's try to check what are the ventricular-arterial connections. Oh yeah, this is beautiful. You can see that the main pulmonary artery is arising from the left ventricle and it stays on the left side, as we shown on the lecture. You can see the branches, the left pulmonary, right pulmonary, and the arterial duct. Now let's focus on the right ventricle and the ventricular arterial connection from this segment. You can see that, oh yeah, yes, move to the aorta. Oh, great. So this is a singular vessel that is seen at the level of the free vessel and trachea view, which is a typical characteristic feature of the transposition of great arteries. So that, I hope this is clear. Can you show us, Peter, the 3D aspect of this anomaly? If you switch to 3D, and in a 3D demonstration, it is, and can you move your section to the front of the heart, that we can see it from the outside. Yes, this is beautiful. And look, you can see that the aorta is rising from the ventricle, which is positioned anteriorly, and the main pulmonary artery, we can see the left pulmonary artery very clearly, is positioned more posterior. So the aorta is to the right and to the front of the main pulmonary artery. This is why we call this anomaly as detransposition. Peter, can you move back to the levels now? First show us the aorta. Yes, beautiful. And the main pulmonary artery. Yes, beautiful. If you are carefully watching, you see that we are navigating within the heart by the routine sweep. So not many angulations are done, almost nothing. So this is the simplest scanning technique as it is possible in the prenatal scan. So we go slightly, level by level, slowly, and we are trying to build this segmental picture of the heart. Peter, can you show us now the normal heart from 3D perspective?
Yes, I will switch in a second.
Yes. We were working on this VR system in order to make it, first of all, budget friendly and easy to use. This is like the pilots are trained on simulators. Unfortunately, the sonologists and sonographers are not trained this method yet. But I hope, thanks to the tool like ours, the future will change it. So Peter, can you show us the 3D picture now from outside, as it was demonstrated beautifully in the transposition?
Yes.
All right. Yeah.
Okay.
Oh yeah, beautiful. And please appreciate that from the your anterior ventricle, the vessel that is rising is leading us straight down towards the descending aorta. And this line is, as Professor Rudolph suggested, is one of the main geometric lines, and it may be called pulmonary ductal trunk. It's a straight line. Look at the connection of this line with the transverse aortic arch, and this is why they form these two arches. They form the V sign. This is not possible to be visualized in the postnatal life because of the chest, which is highly ossified, and because of the lungs, which are obstructing the view, and we are limited in postnatal scanning to separate windows, to several windows that are giving us the full picture. However, in the prenatal ultrasound, we can scan like in MRI, because the ossification of the ribs is not so strong, and also the lungs are not filled with air. So we have good points, but we need to know how these anomalies look like, because based on the normal picture, we won't be able to diagnose these problems. Peter, can you show us now the double outlet right ventricle with the subpulmonary VSD?
Yes.
Okay, and let's have a look at the 2D picture first.
Yes, we are there.
Okay, excellent. So let's start with the veins. IVC is seen beautifully. Let's follow IVC in transverse view towards the right atrium. Excellent. One of the pulmonary veins is seen that drains to the left atrium. Beautiful. We go further. Perfect. And left ventricle, right ventricle, they are clearly demarcated. Next, move upwards, please. Important remark for the, oh, I can see the VSD, right? And let's focus on the great vessels now, because we should expect at this level the aorta. But look, there is a vessel. The first vessel that we can see is the main pulmonary artery that arises from the right ventricle. So just imagine, as I shown you on the lecture, that the blood will move from the left ventricle through the VSD to the main pulmonary artery. If you move slightly higher, you should see, yeah, that it was clearly shown. You can see the aorta and forming the aortic arch. Beautiful. Yes, Peter, can you show us in 3D how it looks like from outside? Yeah. We started this story with 3D printouts. However, this printing technology is quite expensive, and I think the 3D printed models are more used in the during counseling in tertiary centers. However, this VR system as a simple simulator for congenital heart diseases is more open for any user, any specialist, any trainee involved in prenatal diagnostics. Beautiful. Peter, let me continue the speech. I hope it was clear. We strongly encourage everybody who is listening to check our VR system. We'll give you the details. The project is ongoing and is being developed very strongly now, thanks to our colleague Jill Bython from the US, who is one of the leading teachers in fetal echo in States. Peter, can I switch to the presentation? Okay, perfect. So now let's move on. I think we covered the most important part that was dedicated to detransposition, and this is why we started with that one. But now we will continue with tetralogy of Fallot and other anomalies which are grouped in the aortic dextroposition anomalies. These anomalies may also be ductal dependent, but here the most important issue is to focus on the main pulmonary artery and its branches, because this is the crucial point. In this group, we can highlight the VSD, which is not related with the infungibular stenosis that is characteristic for tetralogy of Fallot. You can see very narrow main pulmonary artery and very small the arterial duct. If the overriding aorta is more committed to the right ventricle, like here, then we are calling this double outer right ventricle in the setting of tetralogy of Fallot, because there is no mitral arterial continuity, and more than 50% of the aorta is committed to the right ventricle. So let's have a look at some ultrasound pictures here. You can see the overriding vessel. You rotate to the right outflow tract and you can see the vessel that is bifurcating. So there is no narrowing of the main pulmonary artery. At the first sight, you can always and you should measure. However, it is not tetralogy of Fallot. If, on the other hand, the overriding aorta is related with the pulmonary stenosis, you can see that the main pulmonary artery is very small. Then this anomaly is called tetralogy of Fallot. The third option in this continuum of problems is when the aorta is pushed more to the right and committed to the right ventricle. Whenever you are talking about the great vessel anomalies, you should focus on the arterial valves. Here you are the main pulmonary valve, and this is the aortic valve. In this case, the main pulmonary artery is anterior to the aorta, which is posterior. But in some cases, and this is related to about 1/3 of cases of tetralogy of Fallot, these vessels may be parallel. But in the majority of cases, the main pulmonary is anterior. So before, we thought that all cases that are seen with the sign of overriding vessel are potentially tetralogy of Fallot, like this one. But you have to remember that under this picture, you can have just a VSD without any infungibular stenosis of the main pulmonary artery, and without the risk of ductal dependent pulmonary circulation. But also you can have tetralogy of Fallot, or you can have double outlet, called by others tetralogy Fallot, like double outlet right ventricle. These anomalies are characterized by the ventricular-septal defect with the superior anterior deviation of the conal septum. And this typical VSD is causing that the blood is brought from the left ventricle and from the right ventricle to the aorta, and this causes its dilatation. And in many of these cases, it is related with the pulmonary stenosis, but very typical pulmonary stenosis, which is called infundibular, because normally if you are talking about the valvar pulmonary stenosis, then the main pulmonary artery is dilated, above the narrowing. But here, the whole picture is of the main pulmonary is dilated, is narrow. Sorry. So let's have a look at this picture. You can see the overriding aorta, and this is the main pulmonary that is very wide. So this case should be called VSD. Some experts call it VSD of Eisenmenger complex type. Whenever you have doubts, you should measure the main pulmonary artery and its branches, because these are the prognostic factors. When we discuss with our cardiothoracic surgeons, they are very aware of any cardiac anomaly that is related with the narrowing of the main pulmonary artery branches. This is why in this group of anomalies, this is one of the major prognostic factors. You can use Z-scores, and in Krakow, we routinely use Z-scores for these anomalies, because these are the predicting factors of the development of pulmonary artery branches. However, in tetralogy of Fallot, the infundibulum is underdeveloped. The muscle fibers in the outlet portion of the right ventricle are hypertrophic, and by this hypertrophy, the outflow portion is obstructed of the right ventricle, and that causes the infungibular stenosis of the main pulmonary artery. You've seen the detection rates of tetralogy of Fallot which is around 30%. But I think the major reason here is that we didn't focus on the main pulmonary artery. We were just focusing on checking the septo-aortic discontinuity on the overriding aorta, and we didn't focus on the main issue, which is the infungibular pulmonary stenosis. So if you understand tetralogy of Fallot, then you won't have any problems with detecting this anomaly. Some experts say that everybody from prenatal ultrasound has her or his own tetralogy of Fallot that was missed. Of course, this is true. However, you can minimize missing this anomaly, especially when it is DD type, so ductal-dependent tetralogy of Fallot. Let's have a look at the sweep through the heart of tetralogy of Fallot. Overriding aorta, very narrow main pulmonary, and at the level of the free vessel view, you see a narrow main pulmonary, and the level of free vessel and trachea view, you usually see one arterial vessel, which is wider than in detransposition of the great arteries. But the visualization of the singular vessel depends at the level of free vessel and trachea depends on the degree of narrowing of the main pulmonary artery. If the narrowing is not so severe, then the duct is visible, and then you see the disproportionate picture of the free vessel and trachea view that I will also demonstrate to you in the following slides. This picture is very essential. Here we have an example of quite severe narrowing of the main pulmonary artery. The arterial duct is arising from the left pulmonary artery. This is the left pulmonary artery. And if you focus carefully there, you can see the duct. But sometimes you may have the main pulmonary artery and its branches, which are not so severely narrowed, but the disproportion at the level of the free vessel view between the main pulmonary and the aorta is very significant. This case was referred by our colleagues from Rzeszów, Eastern Poland, quite recently, and initially it was suspected as common arterial trunk. However, if you look carefully, you will visualize the main pulmonary artery and its branches. Can you see here? And in severe cases like this one, these branches are extremely narrowed. This is why we strongly recommend this course. Starting from 2006, most of the ultrasound machines are equipped with this course measurements. I would explain to those who are not using this course. These are very simple measurement methods that express the measurements in standard deviations instead of millimeters. For example, MPA diameter is -5 standard deviation according to BPD, which means is extremely narrow, because in biology and in medicine, we accept a range between -2 and +2 standard deviations. If you look at the gestational age as a reference, it also is reaching more than 4.5 standard deviations minus. So this case is severe, and this case is at the risk of developing the ductal-dependent pulmonary circulation, so it will probably need prostaglandins applied postnatally. Here is another case with the severe narrowing, but forgive me by flipping this picture. Right side is on the left, but I couldn't present it in a better way. Of course, with pulse wave Doppler, you are checking the velocity profile in the main pulmonary artery. In cases which present the severe narrowing, you may expect very high velocities, like in this one, we are exceeding 240 centimeters per second. But sometimes you are reaching quite acceptable velocities, like here, 150. But keep in mind that about 90 is the maximum velocity for main pulmonary artery. Here are some pictures with color mapping. Main pulmonary artery, 3-vessel and trachea view, overriding aorta. Try to build this picture of anomaly from 2D views into the 3D picture. We are a great enthusiast in Krakow of 3D ultrasound in the fetal part, like for example the stick technology. But today we believe this is not the best way for trainees to learn by stick, because the scanning conditions must be perfect. The reviewing is quite time consuming. It's good for lecturers, however, for trainees, it is not recommended in our opinion. Here you can see a nice picture of the tetralogy of Fallot with less severe narrowing of the main pulmonary. And what is characteristic here is that the V sign is slightly atypical. The arms of the V sign, especially the pulmonary arm, is not joining with the ortigon at the end. It's joining at the half point. Can you see that? Of course, this is not true. This is just our imagination, because just imagine that the arterial duct is quite narrow, and it probably is lying behind and joining the descending aorta at the same point as in the normal heart. However, it is too narrow to be seen at this level. This, as we call the Y sign, is a helpful sign for tetralogy of Fallot independently on the gestational age. We have described this phenomenon also in the first trimester. I will give you a reference later. Here is the reference. It was described in 2018 in J1. And just have a look at the early cardiac scan, the normal V sign, and the Y sign. The very narrow, if you understand now the narrowing, the infungibular narrowing of the main pulmonary, and the connection between the main pulmonary and the aortic arch, at the level of the 3-vessel and trachea view through very narrow arterial duct, then you will be able to be more focused on tetralogy of Fallot, also in the first trimester. But what is important is the position of the probe. Can you appreciate that I'm pointing the probe directly to the main pulmonary, to the right outflow tract? It assures me that I'm scanning under the proper angle, and it means that this signal of the main pulmonary is the strongest available. Here you have the Y sign in a 14-weeker. This is a scan performed with the 3 to 10 megahertz probe. In our eyes, the best probe that is available now on the market. And this 14-weeker developed the overriding aorta. And look at the Y sign. This baby was confirmed as tetralogy of Fallot, also later in gestation. This is the main pulmonary, and this is the transverse aortic arch, and look how big it is in relation to the main pulmonary artery. So if you are careful about the V sign, because about the pulmonary arm of the V sign in the first trimester, this will enhance the detection rate of tetralogy of Fallot in the first trimester. And keep in mind, is one one of the commonest anomalies in this group. Tetralogy of Fallot may be found in combination, so don't give up with your diagnostics, with your ultrasound analysis when you have found the features of tetralogy of Fallot. You have to look also for additional cardiac problems and extracardiac problems. One of the combination is the AVSD together with tetralogy of Fallot. Please appreciate the common valve, the overriding aorta, very narrow main pulmonary, and the singular arm of the V sign and the free basal and trachea view. This combination is found almost in the major in plenty of trisomy 21 cases, and it is rarely found without trisomy 21. Another additional anomaly is right aortic arch, and keep in mind that right aortic arch is found in about 1/3 of tetralogy of Fallot cases. This yellow line is highlighting the position of the trachea, and I will activate the clip. You will see that the transverse section for the aortic arch is showing this arch on the right side of the trachea, and also in this case the ductal arch was right-sided. This is the aortic arch. This is the trachea. It was here, and the arterial duct, which is extremely tiny, it's coming behind. This is the trachea. It was also right-sided. Here is another case. This is the position of the trachea, and the right-sided aortic arch is also very characteristic because it doesn't give you the oblique position it is normally found in tetralogy of Fallot. It is rather straight. So whenever you have a straight line, think that when narrowing is found together, narrowing of the main pulmonary is found together, think about the right-sided aortic arch in combination with tetralogy of Fallot. As I mentioned before, you may encounter the double outlet right ventricle in the setting of tetralogy of Fallot. Keep in mind that the term double outlet right ventricle is not a term of a specific anomaly. This is one of the variations of ventricular arterial connections. So it means that both great vessels are committed to the right ventricle. And in these cases, the VSD is present. And when this anomaly looks similar to the tetralogy of Fallot, but the aorta is more pushed to the right and committed to the right ventricle, and this is called double outlet right ventricle. And this example I've shown you before, please appreciate the aorta that arises almost from centrally from above the right ventricle and the main pulmonary artery. Most of the time it happens that the postnatal description of our suspected cases in prenatal life, suspected of tetralogy of Fallot, they change the diagnosis into double outlet right ventricle Fallot-like. And it's not considered as a mistake. It is considered as the better possibility in postnatal life to diagnose clearly, to set the final diagnosis. Always keep in mind that the prenatal ultrasound is always the elementary, is the basic diagnosis. The final diagnosis is always based on postnatal echocardiography or autopsy findings. Here is another case, double outlet right ventricle, once again, aorta and the main pulmonary. Aorta and the main pulmonary. In this case, the main pulmonary artery is positioned anteriorly to the aorta. You can also have the variations of tetralogy of Fallot, and I have to mention about the two major variations. One of them is pulmonary atresia, the tetralogy of Fallot with pulmonary atresia. So this is the severest case, which is ductal dependent. It is quite difficult to differentiate these cases from typical pictures of common arterial trunk because of the severe underdevelopment of main pulmonary artery in many cases. Try to focus on this clip. This is the aorta overriding, and here we have the branches of the main pulmonary artery overriding aorta, the branches, and this is the level when the main pulmonary artery valve, pulmonary valve, is closed. Here we are. One moment. Okay, can you see it? Color mapping helps a lot. This is another picture in grayscale. This is the bifurcation, and here is the closed pulmonary valve. And you see very tiny branches of the main pulmonary, which are poor prognostic factors. The color helps because when you put color on, then the duct is filled from the aortic arch, and you can observe the retrograde flow through the arterial duct and antegrade flow to the branches of the main pulmonary artery. And this red color is the retrograde flow, and this is the level where the pulmonary artery was closed. Can you see here? Here we have another picture. The branches are seen, and there is a difficulty to connect these branches with the right ventricle in the ultrasound picture, of course. And the color mapping helps a lot. In red color, you can see the retrograde flow through the duct. When you are diagnosing a case of tetralogy of Fallot with pulmonary atresia, keep in mind that the additional connections between the aorta and the lungs are usually present in these cases. So we have to search for connections called MAPCAS of the descending aorta, and this is one of the MAPCAS here in red color, bringing blood, supporting blood to the lungs. When you compare a classical tetralogy of Fallot with tetralogy of Fallot with pulmonary atresia, some American authors mainly call this anomaly as pulmonary atresia plus VSD, in contrast to the pulmonary atresia with intact interventricular septum. You have to remember that when pulmonary atresia is found, the aorta is more dilated. So the smaller is main pulmonary, the bigger is the aorta. And MAPCAS are present. The duct shows retrograde flow. It is tortuous and occasionally dilated. And in the pulmonary atresia group, in about 20%, you will find the microdeletion Q11. However, in classical tetralogy of Fallot, the more common are major trisomies. Another variant of tetralogy of Fallot is absent pulmonary valve syndrome, which is characterized by the obstruction at the level of the pulmonary valve, which was not formed in this case. The reason for that is probably the absence of the arterial duct, and in ultrasound picture you are encountering the bidirectional flow at the level of unformed pulmonary valve and the severe dilatation of the main pulmonary artery branches. So this is very characteristic. Whenever you see this is the transit section through the aortic arch and the dilated main pulmonary arteries, think about absent pulmonary valve syndrome, which is a rare variant of tetralogy of Fallot. However, you should remember that absent pulmonary valve syndrome may be also found in other anomalies like detransposition of great arteries, for example. So in cases without tetralogy of Fallot. Here you see the bidirectional flow of the main at the level of expected pulmonary valve. In a pulse wave Doppler, the reading presents very high velocity in this bidirectional fashion. Peter, can you demonstrate to us the features of tetralogy of Fallot in the virtual reality system?
Right away.
Okay, excellent. How are you, Peter?
I'm good. How are you, Martin?
I'm doing quite well. I hope the audience enjoy it. We cannot interfere. We cannot hear them. This is quite difficult. I can imagine what the football players feel when they have no audience, because this is the first course that we are giving without audience.
Yeah, fortunately, we have chat, and any question that you actually want to be answered, you can always ask in the chat. And we are seeing the VR stream, Marcin, so you can proceed.
Excellent. Okay, so is this tetralogy of Fallot?
Yes.
Oh, excellent. So maybe let's start with the 3D picture. Let's look from outside. Oh, excellent. So you can see from outside how the aorta is pushed to the right. This is why this group of anomalies is called aortic dextroposition anomalies. And you can see the typical picture of the infungibular pulmonary stenosis. Look how small is the main pulmonary in size, and how small are the branches of the main pulmonary artery. So Peter, can you open to us the 2D pictures, because we understand that the geometry, and let's present it into 2D. So from IVC, I can see it enters the right-sided atrium, left atrium. We can see that the left atrium is connected with the left ventricle. Both AV valves are patent. Okay, so let's move towards the great vessels. Oh, nice. Now we can see that the vessel that is seen first, I mean the arterial vessel, is arising just from above the VSD. Okay, let's follow these vessels and let's analyze if we have branches. No branches so far. Okay, so it seems that this vessel is the aorta. We also could see a small signal of the second vessel. And we can see it. This is the main pulmonary artery. Now Peter is showing to us the tiny vessel. Yeah, it's here. And this is why you have to be very careful if you scan tetralogy of Fallot, especially of this type, as it is seen now with the severe infungibular pulmonary stenosis. Now, Peter, can you show us in 2D the relation between the main pulmonary and the aorta? You can see that the aorta is dilated, the main pulmonary is very narrow. Can you show us the branches of the main pulmonary? Oh yeah, they are very hardly to see. Yeah, they are there. They are very tiny. Can you show us, Peter, with the laser pointer? Oh, excellent. Yeah, just the left pulmonary and the right pulmonary artery. Excellent. And Can we try to see the duct, the arterial duct? Oh yeah, there. It's very tiny. It arises from the center, but it's really hardly to visualize. And the same problems you can encounter during. Oh yeah, now Peter is showing the arterial duct now. And the same problems you can encounter during your routine prenatal scan in tetralogy of Fallot. So remember this picture and keep remember also about the spectrum of aortic dextroposition anomalies, that it may be just the VSD, it may be the tetralogy of Fallot, or it may be the double outlet right ventricle of Fallot-like. Peter, thank you. It was wonderful.
Thank you.
Give a look. Let's give a look at the two remaining problems that are included in the group of great arteries anomalies. First, I would start with common arterial trunk. Common arterial trunk is also the anomaly when the septation of the primary common trunk was distorted. And there is just one vessel arising from the ventricular segment of the heart. There are some variations of main pulmonary artery or the branches origin. And I will try to show you some examples. The most common type is when from the common arterial trunk, the main pulmonary arises and that bifurcates into the left and right pulmonary artery. You can have the type A2 when both branches are arising directly from the common trunk. You may have type A3 when one of the branches arises from the common trunk, and the other branch is arising from the aorta descending. And next type is A4 when you have discontinuity of the aortic arch. Normally, the arterial duct is not needed in common arterial trunk from the embryologic point of view, but in cases when the discontinuity happens in the aortic arch, then the arterial duct is developed. And many authors include the pulmonary atresia with MAPCAS, with these additional connections of the descending aorta with the lungs to the group of the common arterial trunk. I've shown you the classification according to Van Praag. Van Praag is the author who is very dedicated to the congenital heart diseases, and he is nominated as the honoris causa professor also of the Jagiellonian University in Krakow. Unfortunately, he couldn't visit us because of the coronavirus story, but the process is successful so far. But he was unable to give his honorary lecture. Let's have a look at the examples. This anomaly is quite similar from the prenatal picture point of view to the tetralogy of Fallot. And most of the time you may have doubts if this is a case of common arterial trunk or a case of tetralogy of Fallot. Can you see the common valve? This is the common trunk, and from the common trunk, the main pulmonary artery arises. This is the part of the trunk that is forming the aorta. So the cardiothoracic surgeons, they do the treatment which is based on forming the neo-aorta from the common arterial trunk, and the connection of the pulmonary artery with the right ventricle, together with the closure of the VSD. VSD is almost always present. According to Van Praag classification, the type B of common arterial trunk is the type without VSDs. This is another case. You can see the common valve, the main pulmonary artery origin is not connected with any valve. So this valve brings the beginning, gives the beginning of the main pulmonary and aortic part of the common trunk. Here we have the type A2, and from the common trunk, both branches of the pulmonary artery are arising directly, and quite often in this type, the free vessel and trachea view gives a typical picture when the aortic arm is placed horizontally within the fetal chest. Can you see the horizontal position? In many cases, especially of this type, you may encounter this feature. Here is the type A4. It was very severe. This baby unfortunately died. This is the common trunk given branches, and also look here. This branch is the arterial duct, and that was the case of aortic arch interruption. In color Doppler, you can see that vessel, the common arterial trunk, was arising from above the right ventricle, and it was giving the aortic part, the pulmonary part, and the duct was present. Most of the time, the valve of the common arterial trunk is of multi-leaflet origin. This is why we are observing prenatally the insufficiency of the common valve. So whenever insufficiency of the arterial valve is found, and we have doubts about the diagnosis, about the differential diagnosis, this is one of the leading points towards the common arterial trunk. But in our experience, we have seen cases of pulmonary atresia with tetralogy of Fallot, presenting also the insufficiency of the arterial valve. So don't take it as the sign which is 100% typical for the common arterial trunk. And the next and final anomaly that we have to discuss today is the L transposition of great arteries. L transposition is very special. If you have cytosolitis, in these cases, the cardiac tube is rotated not to the right, but to the left, which causes that the right ventricle is on the left side, and the left ventricle, the left ventricle is on the right side, the right ventricle is on the left side. So we have the two features here, which are two discordances between the atrioventricular connections, meaning that the left atrium is connected with the right ventricle, and the right atrium is connected with the left ventricle. And the second discordance at the level of the great arteries, which means that the aorta arises from the right ventricle, and the main pulmonary arises from the left ventricle. In this anomaly, it is called L transposition. It means level, left, because the aorta is on the left from the pulmonary artery. This is very characteristic setting. So if you look at the geometric side, geometric features, the left ventricle that is connected with the right atrium gives the rise of the main pulmonary artery. And there is a fibrous continuity between the mitral valve and the pulmonary valve. The examiner has very easy can very easily demonstrate the origin of the main pulmonary in this case. But the aorta is arising like here, giving the short convexity sign from the right ventricle. And at the first sight, you should see the discordance between in atrioventricular connection. Look, this is the left atrium. It's connected with the right ventricle. This is the moderator band. In unexperienced hands, it may look like hypoplastic left heart syndrome. But don't forget about the basics. This is the morphologic feature of the right ventricle. Here we have the right atrium, and the right atrium is connected with the left ventricle. You can see a bullet shape of the left ventricle. You can see that there are not fine, there are not coarse trabeculations within the lumen of this ventricle. Another case: left atrium, right atrium. Typical bullet shape of the left ventricle. So we have atrioventricular discordance. Right atrium is connected with the left ventricle, and the left atrium is connected with the right ventricle. You can see the moderator band very clearly. Don't forget that the moderator band is the best seen from apical position or from basal position. Basal position means when in your screen the apex of the heart is pointing down. And regarding the ventriculo-arterial connections, the left ventricle gives rise to the main pulmonary artery here, okay? And the right ventricle is connected with the aorta. Once again, main pulmonary and the short right convexity sign, typical for L transposition of great arteries. This anomaly is considered as one of the best testing methods for the interpretation skills in fetal echo, because everything is messed up. The connections between the atria and ventricles, and the connections between the ventricles and the atria. Because of double connections, double discordances, these babies are usually asymptomatic, and the symptoms, the presence of symptoms, depends on additional cardiac problems, which are quite often found in L transposition of great arteries. And whenever we have the pulmonary stenosis at the level of the valve, usually these babies have cyanotic problems. What is important from geometric point of view? In the normal heart, from the left ventricle, the vessel that arises is the aorta, and it is led to the right side. If you think about L transposition after diagnosing the discordance between the atria and the ventricles, you may have the impression of seeing the mirror image. The main pulmonary is seen under about 45 degrees towards the left atrium. So it is like a mirror image from the normal heart. And let's analyze L transposition in a very slow sweep. IVC, left atrium, left ventricle, right ventricle, main pulmonary, and the aorta. Once again, IVC, right ventricle, left atrium, sorry, right ventricle, left ventricle, main pulmonary, and the aorta. This anomaly is quite well diagnosed prenatally because it looks unusual and quite often is related with with congenital heart block, and this is another point that makes our diagnosis, prenatal diagnosis, easier. In L transposition, we can have the dextrocardia, and then the assessment is more difficult. But still, if you follow the sequential segmental approach, you won't have any problems. So let's have a look. The stomach, the right atrium, this is the left ventricle. Once again, slowly. Right atrium, left atrium, left ventricle, main pulmonary, aortic valve, aorta. So in cases when dextrocardia is seen, the short right convexity sign of the aorta is not observed. It is usually giving the straight line, but still at the level of free vessel and trachea view, there is a feature of singular arterial vessel sign. You can see one vessel is only seen. So once again, right atrium, left ventricle, main pulmonary. I'm sorry, this is too fast. Left atrium, right ventricle, and the aorta. So double discordance. Quite often in L transposition we have VSDs, and these septal defects are found in about 90% of these anomalies. You can see a VSD, but please appreciate the anterior ventricle is of a typical shape of the left ventricle, which what should catch your eyes, and the moderator band is seen in the ventricle, within the ventricle, which is positioned more posteriorly. There's another case, the stomach, IVC, left ventricle, right ventricle, aorta. Slowly. Right atrium, left ventricle, stomach, okay. Right atrium, left ventricle, main pulmonary, aorta is rising from the right ventricle. Can you see the moderator band? So if you look carefully, you will be able to see all these details. Try to do it alone, in slow motion. We recommend analysis in slow motion, which is very didactic, in our opinion. This is the case of L transposition in which we have found the complete atrioventricular block. We can see the ventricular contractions together with atrial contractions, and you can see the blockade of signals. In early cardiac scan, as we discussed early features of detransposition, early features of aortic dextroposition anomalies, we also should rate the early features of L transposition. And one of the major features is the short right convexity sign. Let's compare the normal picture. This left side is the right side, and this is L transposition left side and the right side. Main pulmonary and the aorta. So this is the relation of the great vessel when the aorta is on the left, from the left to the main pulmonary artery. So it's difficult, however, it's doable, and we have found some cases of transposition in the first trimester. Now we are building the database of all these cases. So there are geometric features. I would like to thank you for this topic, and remind you that we are scanning such a tiny picture. Can you see that? Peter, can you see my camera? Okay. Okay. So this is the size of the heart at about 20 weeks. This is the size of the smaller than the thumbnail. So prenatal ultrasound is a difficult task, but as you have seen today, we can do a lot. I would like to ask Peter to present features of L transposition of great arteries. Peter, can you show us? Okay.
Sure, Martin, I will show. I'll just wear the goggles again.
Wonderful. Wonderful.
Maybe I will already switch to the view, so we will see what I see.
All right.
Okay.
All right. So,
Okay, I have my goggles on. Perfect.
Okay.
So we want LTGA.
LTGA. Excellent.
Perfect.
And let's start from IVC. Excellent. Okay, IVC. And next, let's move to the right atrium. Here's the right atrium. Here we have the left atrium. And look, there is a moderator band. It was seen. Peter, can you go back a little bit? There is a moderator band seen in the ventricle that is connected with the left atrium, which is very unusual. Yeah? And now we have to concentrate on the morphology of the left ventricle. The left ventricle is a little bit longer at the level of fourth chamber view because of these coarse trabeculations found in the apical area of the right ventricle. Also, the position of the valves, of the AV valves, differs slightly. The tricuspid valve, because remember, the AV valve is always following the ventricle. So this valve is the tricuspid valve, and it is usually more apical in relation with the mitral valve. And now, oh, this is beautiful. You can see the fibrous continuity between the mitral valve and the pulmonary valve. Can you show us more the mitral valve, the valve of the left ventricle? Oh yeah, look, there is they have no any muscle around this area, so infundibulum is not formed here. Okay, this is why they have the continuity. And to look at the position of this vessel, can you show us the branches to be sure that we are talking about the main pulmonary artery? Yeah, they are branches. Perfect. Perfect. Okay, we can see. So we are now sure that this vessel that is arising from the left ventricle is the main pulmonary. And let's try to visualize the vessel that arises from the right ventricle. Oh yeah, it's here. And this is a beautiful example of the short right convexity sign. You can see that this sign is seen as quite similar to the right convexity in the D transposition, but this is starting from the center of the heart. In D transposition, you have the right convexity starting more anteriorly. So this is another point that will help you with diagnosis of L transposition of great arteries. Peter, can you show us the 3D picture?
Sure.
Oh yeah, perfect. And let's start from the outside, and you can see that the aorta, because you can see brachiocephalic vessels, is the origin of the aorta is surrounded by the strong muscle fibers, because we have the subaortic infundibulum here, and there is no fibrous continuity between the tricuspid valve and the aortic valve. And also you can see that more posteriorly and to the right, we can see the main pulmonary artery. Can you see it? It's behind the aorta that is giving the convexity. Can you enter these layers now? Excellent, excellent. Oh yeah, stop here, please. And here you can see that a very strong rim of muscle around the origin of the aorta. So this confirms that we are talking about the infundibulum that is placed below the aorta. In the normal heart, the infundibulum below the aorta is absorbed, and is only remaining the infundibulum below the main pulmonary artery. So this is opposite. Peter, okay, yeah, this is beautiful. Okay, I think we have it. So do we have any questions from the chat? Nothing? So it means it was clear. I hope.
We can wait a moment. Still, maybe someone has some questions.
We are delayed of about 8 seconds. So if you have no question, we can go directly to the quiz. The quiz covers 10 cases. And within these 10 cases, we'll give you some questions. Are you ready for the quiz? If you were listening carefully, you wouldn't have any problems. Oh my God, they didn't listen. Wiesz co, jest tam problem z rozmawiam, tak? Okay. Okay. Perfect. So let's start the quiz. Ready? Okay, perfect. So most of the clips I'll slow down. If you are ready, we can start. This is the first case. Left atrium, probably. I think this is fully enough. And let's have the questions. You can send your questions through the chat. Answer A, is this hypoplastic left heart syndrome? Answer B, is this cardiomyopathy? Answer C, are these discordant atrioventricular connections? Answer D, is this tricuspid atresia? Let's go back to the clip. Excellent. And again, the answers. Please put your answers. You can send us.
The answers are appearing.
Appearing, fantastic.
Great. The answer is C from most of the people.
Most of the people, fantastic. Let's go to the question number 2. Case number 2. Left and right side is highlighted. Slow motion. Focus on the arterial valve. This is very important in all the great vessel anomalies. Good. So, is this pulmonary stenosis? Is this detransposition of great arteries? Is this VSD? Or maybe this is double outlet right ventricle. Let's go back. Perfect. So potential answers: pulmonary stenosis, detransposition of great arteries, VSD, or double outlet right ventricle.
The answers are appearing. The first one was given by Vladimir, and that was B. But we have also one D, so double outer right ventricle.
I cannot tell you now which answer is correct. We'll discuss them later.
So you will give all the answers at the end, right?
Oh, of course. Of course. Now test yourself.
Fantastic. Okay, we have also 1A, 1C, 1D, whole spectrum.
Excellent.
So case 2 is quite tricky.
Can I proceed? Can I go further?
I would wait just a moment for a few answers and then proceed.
Excellent. What do you think, Peter? Can we go on?
Let's proceed.
Okay. Case number 3. I hope that slow motion will help you. It is all about remembering the features and understanding the connections between the ventricular and arterial connection and arterial segment. Okay, potential answers: pulmonary stenosis, detransposition of great arteries, VSD, or double outlet right ventricle. Let's go back.
Okay, no answers yet.
No answers?
Yeah.
Okay.
Okay, there is first one from Eugenia. It's D.
Pulmonary stenosis, detransposition, VSD, or maybe double outlet right ventricle.
We have two answers now, both saying D. Four answers now, and one person saying B.
Okay, should we wait a little bit?
Yes, maybe also show all the answers for a moment.
Okay.
Two votes for B and four for D.
Not many people are answering. I strongly encourage you to participate. Don't be afraid. So, shall we go further?
I think so.
Okay, case number 4. Okay. What are the potential answers? Tetralogy of Fallot, detransposition of great arteries, normal heart, or maybe right aortic arch. Let's go back. Excellent.
So we have the
Okay.
first answer. First answer is B.
Okay.
Again from
Tetralogy of
Evgenia.
Fallot, detransposition, normal heart, or maybe on the right aortic arch. And last chance for the case number 4. The potential answers once again. And we move to the case number 5.
Yes, this time most of the people agreed that this was B. We'll see later.
Wow, we'll see later. Okay. So, right side, left side. Okay, potential answers. Is this hypoplastic left heart syndrome? Is this cardiomyopathy? Discordant atrioventricular connections? Or maybe tricuspid atresia? For sure, this is not ventriculomegaly or renal pelvis dilatation, which are the most favorite answers for any anomalies in the fetus.
Okay, we have some first answers that arrive.
Good.
C and B is appearing.
Hypoplastic left heart syndrome, cardiomyopathy, discordant atrioventricular connections, tricuspid atresia. Once again, last chance to solve the case number 5. The answers, and let's go to the case number 6. Ready? Let's go. Peter, are you sure that Professor Ximenez is with us?
Yes.
Excellent.
I think he was answering before.
Yeah, because Okay, let's have the answers. Tetralogy of Fallot, detransposition of great arteries, normal heart, right aortic arch. Let's go back. I think this case is very easy.
Yes, Professor Ximenez is with us on the chat.
Oh, thank you. Thank you, Renato. Good. The answers. Tetralogy of Fallot, detransposition, normal heart, or right aortic arch. It was easy, so let's proceed to case number 7. the answers: pulmonary stenosis, detransposition of great arteries, VSD, or maybe double outlet right ventricle.
Okay, we have first answers appearing for case 7 from
Excellent.
Natasha this time. A.
Excellent.
But people are quite active. We are answering. I'm very happy.
Ah, that's good. That's good. That's good. Pulmonary stenosis, detransposition, VSD, or maybe double outlet right ventricle. Let's proceed to case number 8. Okay. The potential answers: tetralogy of Fallot, detransposition of great arteries, common arterial trunk, or maybe normal heart. Peter, do we have some people answering?
Yes, but let's give a bit more moments for case 8 still. Okay?
Okay, okay. So the answers, potential answers: tetralogy of Fallot, detransposition of great arteries, common arterial trunk, and a normal heart. Once again, the clip.
I think all the answers are C in this case.
Or C. Oh my God. Do we have all the answers?
I would say we can proceed probably.
Okay, last chance to choose the option in case 8. And let's move to case 9. And in case 9, we'll have 2 clips. Clip number 1. And clip number 2. The answers: pulmonary stenosis, detransposition of great arteries, VSD, or maybe tetralogy of Fallot. So let's move to the first clip. The second clip. And the answers: pulmonary stenosis, detransposition of great arteries, VSD, or maybe tetralogy of Fallot. Peter, do we have some answers?
Not yet. I think because of the delay, we have first answer now from Evgenia that this is D.
So let's have a look at this case, last chance. Potential answers. And let's move to the final case, case number 10. In slow motion. And the potential answers. Hypoplastic left heart syndrome, L transposition of great arteries, common arterial trunk, and tetralogy of Fallot.
This time we had first answer before the answers appeared from Jamie that this is B, LTGA.
That's good. That's good. Okay, and the answers: hypoplastic left heart syndrome, L transposition of great arteries, common arterial trunk, and tetralogy of Fallot. The last chance.
I think we have all the answers.
Excellent, good. So let me go through these cases. So case one. In case one, you can see left atrium connected with the right ventricle, right atrium connected with the left ventricle. So the proper answer was discordant atrioventricular connection. You can have isolated discordant atrioventricular connection without L transposition. It's possible. This is why you have now this option here as the potential answer. How about this one? Let's move from the beginning. So this is the left ventricle, left atrium, right atrium. This is the right ventricle. You can see the trabeculations. Here we have the typical shape of the left ventricle. There is a great vessel with the valve and another vessel with the valve. We hardly can see the continuation between the mitral valve and the aortic valve. This is why we should think rather about double outlet right ventricle than about tetralogy of Fallot. So here pulmonary stenosis was present, but it was in the setting of double outlet right ventricle. It wasn't the transposition of great artery. VSD was also a part of this anomaly because without VSD, the double outlet wouldn't be possible. However, this is a typical picture of aortic dextroposition anomaly. So if you say tetralogy of Fallot, that also would be correct. However, with discontinuity between the mitral and the aortic valve, you should rather call it double outlet right ventricle. Case 3, IVC, left atrium, left ventricle, right ventricle, and from the right ventricle one and another vessel is rising. They are almost one next to another. So this is a different type of double outlet right ventricle, and the answer is D. This is a double outlet right ventricle with subpulmonary VSD. In other words, Taustig Bing anomaly. How about this one? Not perfect scanning conditions. If you look closely from the beginning, this is the vessel that left ventricle, the vessel that bifurcates, and another great artery that arises from the right ventricle. So this is the transposition of great arteries. The transposition of great arteries, typical picture. How about here? This is the right side, the left side. This is the IVC. These are the pulmonary veins draining to the left atrium. And look, the right atrium is connected with the smooth ventricle and without any strong subacculation. So this is discordance between the atria and ventricle. It may be a part of L transposition of great artery. But in this picture, we are not seeing any great artery. The correct answer is discordant atrioventricular connections. Number 6. Left, right ventricle, aorta overriding, and the infungibular pulmonary stenosis. Please note the pulmonary valve, which is here, and the typical Y sign at the level of free vessel trachea view. You can see Y sign. So it's a good example of tetralogy of Fallot. Tetralogy of Fallot, answer A was correct. Case number 7. Left ventricle, right ventricle. This is the right outflow tract, and now we can see the overriding aorta. And from the right ventricle, we have the vessel that bifurcates. So we have no infungibular stenosis of the pulmonary artery. This is why we should call it VSD. This is a typical mole alignment anterior type of the VSD, but it is a VSD, nothing more. So pulmonary stenosis is wrong, the transposition is wrong, it's the VSD, correct answer is C. Case number 8. This is the left ventricle, right ventricle, and there is only one vessel arising from the ventricular segment, and this is the valve of the vessel here. And you can see the aortic part and the main pulmonary portion. So this is the good example of common arterial trunk. Correct answer was C. Case number 9. You see the narrowing of the main pulmonary, the more prominent aortic arm of the V sign, but it's difficult to visualize the relation between the septum and the aorta. This is why we move to the oblique position of the probe, and you can see that the aorta is overriding. This is why the answer, tetralogy of Fallot, the answer D is correct. And regarding case 10, You see at the first side, right ventricle connected with the left atrium, and the left ventricle, which was connected with the right atrium. And look at the picture of the great vessels. This is the main pulmonary arising from the left ventricle, and the aorta arising from the right ventricle, giving the right convexity sign, but very short, short convex is seen here. So this is the typical picture of L transposition of great arteries. L transposition of great arteries. The answer B was correct. Ladies and gentlemen, I hope we helped a little bit with giving you pictures and patterns of anomalies of great vessels. I hope it will help you in your daily practice. If you have any answers regarding the headsets, the VR system that we have developed with the controller, do not hesitate to ask us. Peter and Adrian are very happy to help you if you want to try. Now, this is a budget-friendly, very suitable and easy to use solution that you can use for simulating your fetal echo. Once again, thank you very much. Thank you, Peter. Peter, will you give us a word for the end?
Thank you very much, also Martin, for the talk. As Martin told, if you have any questions about our VR simulation, just write to us on the messenger or ask us now. We'll hang around still for a few minutes here if any potential questions will appear. Thank you.
Peter, can we have the connection with Professor Ximenes? Can we hear him?
If Professor could join us through the Meet, we can try to arrange that. Let's try to arrange this.
Okay. Okay, so once again, thank you so much, and we are very happy to help. This is the website of our School of Ultrasound, www.mwu.edu.pl. If you have any questions, we are happy to help. Sorry? Call. Okay. Thank you. Thank you for your time.